You're listening to Medscape's In Discussion series on endometrial cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ursula Matulonis, Chief of the Division of Gynecologic Oncology at the Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School. She's the first recipient of the Brock-Wilson Family Chair at the Dana-Farber Cancer Institute. She co-leads the Gynecologic Cancer Program within the Dana-Farber Harvard Cancer Center and an NCI P01 program project grant that is focused on targeting replication stress in high-grade endometrial cancers. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for healthcare professionals.
Hello, I'm Dr. Ursula Matulonis. Welcome to Season 3 of the Medscape In Discussion Endometrial Cancer podcast series. Today, my guest is Dr. Jessica St. Laurent, and we'll be talking about lots of different aspects of endometrial cancer, including prevention, treatment, what are some of the projects she's working on, and other topics such as GLP-1 receptor agonists. First, let me introduce Dr. St. Laurent. She is a gynecologic oncologist and researcher who provides comprehensive surgical and medical oncology care for patients with gynecologic cancers. She is a reproductive scientist development program scholar whose laboratory research focuses on developing a better understanding of the basic biology of endometrial cancer and developing new treatment approaches for gynecologic cancers. So, Jessica, Dr. St. Laurent, welcome to the Medscape In Discussion Endometrial Cancer podcast.
Thanks so much, Ursula, for having me, and thank you so much, Medscape, as well.
So let's start. A lot to talk about, lots of new developments, but it's really great to have you on the podcast to talk about what you're doing in the lab and where you see the field going. Kind of briefly tell us, the audience, about how you became interested in gynecologic oncology as a career, and then focusing more on endometrial cancer.
I have a family that has breast and ovarian cancer syndrome, and it became obvious that there was a person in my family that we thought had ovarian cancer and ultimately ended up having an endometrial cancer diagnosis. So early in my career, I was focused on breast cancer research and the early biology of the development of breast cancer. I became acutely aware that we have come very far in the breast cancer field in terms of treatment, in terms of our understanding the biology, and realize that we have so much to learn and gain in the endometrial cancer field. And certainly throughout my early career, we've made great strides, but it became a really exciting place where I could see that we could take a lot of the parallels from the breast biology field and start to focus on some of those same concepts in endometrial cancer. And as I went through my residency and fellowship training, started to hone that interest, and ultimately decided that it was a place that became what is now a very exciting field to be a part of.
I see you as that triple threat, right? So you're a clinician, you're a surgeon, you take care of patients, you teach fellows and residents, and you run a basic laboratory doing basic science research. So that's a lot to handle in a career, but sort of tell us about some of the challenges running your own lab and doing basic science research right now.
It was a very interesting time to decide to start a lab. Thinking about the first signing a contract to start a lab was around the time that we also found out there may be big changes to funding. I think we are at a time right now where foundations have also decided to take a step back and kind of refocus and think about their priorities. So that has been one of the hardest parts. Is as exciting as the biology is ready, I think there was a year or so at the beginning of the time of starting the lab where it wasn't clear what was going to be available for sources to look for funding. I think we've gotten some great news this week in terms of the budget from the NIH and really seeing that there is a prioritization of looking at endometrial cancer research in our DoD programs as well. So I think that's really shaping up. I think there's also the funny challenges, like we're talking today and I'm sitting in a pair of scrubs, which means we're in a transition running between laboratory and the operating room. But I think that's also the nature of what I think is the important contribution of the surgeon scientist, is being able to go and look at the early stages and biology of the disease and then figure out how we can apply that to the treatment that we provide and prevention. But certainly it has had its comedic moments of running between the two jobs.
Yeah.
I think that the basic biology part of the laboratory is something that I've really appreciated and think is an important contribution that we can teach our fellows and our trainees to at least value in their practices, but also being able to kind of start bringing up that early crop of scientists along with the lab.
Yeah. And I think you're clearly a role model. So, you're going to inspire that next generation of G1 oncology fellows to run their own lab, and that you can do it. So thank you for your work there. And also congratulations on your recent paper published in Nature Genetics a few months ago on SWI SNF complexes in dedifferentiated endometrial cancer. So tell us about this research, including what are SWI SNF complexes and how your research impacts or may impact endometrial cancer.
Thank you so much. And it was such an exciting collaborative effort. During my fellowship and did some postdoctoral research time in the laboratory of Sigal Kadosh, who has a focus on the mammalian SWI/SNF chromatin remodeling complexes. We may be more familiar in the clinical context with the one subunit of this complex, which is the gene that produces the protein ARID1A. We often encounter mutations that are reported out on our next generation sequencing reports, and they're very common. ARID1A is mutated in about 66% of endometrial cancers. And in my training, we really referred to these as passenger mutations. We thought maybe they were just an acquired mutation that didn't change much about the cancer biology. But I, went back and thought, these are so common. How do we know that they are not impacting the biology in a substantial way, particularly in endometrial cancers where they're so common? The mammalian SWI/SNF chromatin remodeling complexes are these large multimer complexes that are between 15 and 25 different subunits that comprise 3 forms. So they're very complex, but they ultimately change and shape the way that DNA is organized in the cell and what genes are turned on and off. So you can imagine the absence of one of these big proteins, ARID1A, that's involved in this complex may have a substantial impact. And in fact, in the majority of endometrial cancers that have this one loss of the protein, it changes their gene expression substantially. We actually identified a more rare cancer that's been reported to have multiple changes in these complexes called undifferentiated or dedifferentiated endometrial cancers. They're quite rare, but they are about 8 to 10% of all endometrial cancers now that we've identified them. So having changes in multiple portions of this complex, we identified that they really have a substantial change in their gene expression and their ability to resist carboplatin-based chemotherapy, as we might see in our practices, and also may have quite a substantial impact on their biology and their presentation at more advanced stages. In the laboratory, we were able to really show if we were to add back these missing subunits, how the biology changes and they're less aggressive. And we're now trying to use that as a way that we can roadmap better therapies for these patients as well with undifferentiated cancers and understand how it might impact all endometrial cancers. So a lot of work to do still.
I mean, that's really interesting. And I think we are definitely at it's not a bad thing, but probably we need more and new treatments for endometrial cancer. I think, obviously immunotherapy is infiltrated. Antibody-drug conjugates are upon us right now. But I think, to really dig into the genetics, identify potential targets like you're doing is really wonderful. As you know, the incidence of endometrial cancer, although the 2026 numbers look about similar to 2025, but they're the highest that they've ever been in the United States. Mortality, though, continues to worsen for endometrial cancer. And I wonder, with the increased use of these drugs called GLP-1 receptor agonists, how do you think that the increasing use, if they're increasing, how that will impact endometrial cancer prevention as well as treatment? We know that these drugs will cause weight loss in people and as well as help glucose elevation, but will they make an impact on endometrial cancer?
Yeah, we started investigating GLP-1 approaches to potentially treating and preventing recurrence of endometrial cancer a few years ago. And at that point, there were no patients coming into my practice that were on the medications when they first developed. Now, I would say with a new endometrial cancer diagnosis, primary care doctors are actually starting people on them when they come in to see us in practice. And there are also a lot more people that have been on them. So we are still seeing endometrial cancer diagnoses, but the GLP-1s have really started to permeate in the primary care practice. And I think we'll now start to see the effects of those on the development of endometrial cancer. There have been a couple of really nice studies that have shown that GLP-1 drugs probably act in a similar manner to weight loss through other mechanisms like calorie restriction or surgical weight loss. So it's probably through weight loss and metabolic changes that they act, not directly on cancer prevention itself. That's been shown actually, and Vicky Big-Jump's group has done some nice studies to show that in murine models as well, that it is a similar mechanism, not necessarily through direct tumor impact. However, I do think that in these meta-analysis studies that this is one of 10 cancers that has been shown to be dramatically reduced in populations receiving GLP-1 therapies, either for diabetes or for weight management. And then more recently, I think there's been some studies that have suggested that we can potentially even harness GLP-1s in combination with progestin therapy for patients that have endometrial hyperplasia and changes that are already suggesting that they're on their way to developing endometrial cancer. So I think we're really at the early stages of implementing these in our practice and starting to really understand how we can harness them. But I really hope that this is going to be a way that we can dramatically reduce the rates. I think one of the hard parts in the current studies is it seems like the data we have so far has shown this is predominantly for people that are at risk of developing endometrioid or estrogen-mediated cancers. And I think we really don't know yet how changes in what we think is the inflammatory milieu and the development of non-endometrioid histology cancers are going to change. And that's an area that we have a really active interest in, both in the prevention and whether or not we see them impact the treatment of patients with non-endometrioid histology.
Yeah. I can see these drugs affecting the lower grade endometrioid adenocarcinomas, but how could they or may they impact those cancers that, are certainly contributing to the increasing mortality, such as endometrial serous carcinomas, carcinosarcomas, clear cell cancers? Any thought how the GLP-1 agonists would affect the different histological, but also obviously as you sort them into molecular categories as well?
Yeah, I think that that's also one of the really interesting questions as we shift away from histology to thinking about the TCGA molecular categories or other molecular categorization. Since it's not a direct impact on the cancer as far as we know, the changes in the inflammatory state of a patient or a person might actually be the mechanism by which you could impact a non-endometrioid tumor. So it's not through a hormonally driven mechanism, but changes in inflammation and the microenvironment are what are the kind of the leading theories at the moment.
It'll be interesting to see how these drugs impact this cancer. And I know that you have multiple ongoing projects, and some of them are related to early detection of endometrial cancer, which, to date, we don't really have an early detection test for endometrial cancer. So can you talk about some of your projects focused on early detection, and how likely do you think one day we'll be able to detect this cancer early?
Yeah, I think one thing that has been deprioritized as something that we tried to look for early detection tests for is the fact that a lot of patients will present with vaginal bleeding. And so we think, well, if we're detecting them early with vaginal bleeding, we're catching all cancers early. I think particularly when we're starting to focus on understanding endometrial cancer by molecular category and by mutational status, that really changes how important it is to understand if all patients coming in with an early cancer really have a cancer that is going to be treated with surgery, whether we're missing patients with things like P53 mutations at the early stage. So when we think about early detection approaches, one thing that we've been really focused on is whether or not we can identify patients by using non-invasive tests, potentially being able to diagnose them before they're coming in requiring an endometrial biopsy using mechanisms like menstrual cups, using early tests like ctDNA tests that are being developed more for treatment, but utilizing them for early detection. I think in a world where we have limited ability to get patients in for endometrial biopsies, there is often a large lag between when someone reports vaginal bleeding and when they actually get a biopsy, and we can say whether or not they have a more aggressive histology like a carcinosarcoma or serous cancer, or they really have a less aggressive endometrioid tumor. And that lapse of several weeks to months, if we could close that by using an at-home test, something they could submit, may really impact outcomes for patients.
Yeah, something to look forward to. And I know you're involved in really a lot of other research projects through your lab and through elsewhere. Any that you'd like to mention and discuss?
Yeah, when I think about how we can improve care in general for endometrial cancer patients, one of the things I would love to see is that when someone comes in the door, we have a lot of the same information that we have for someone with a breast diagnosis. So you get a biopsy, that you have your understanding of the mutations, whether that be just our standard molecular categories, your HER2 testing, all of that information, and then a patient comes in the door and we can do that. It was interesting at a few consortium meetings, we've discussed the fact that that's really been a clinical challenge is how do we actually gather that information when we see new diagnoses? And that's something as a group we've tried to standardize within our institution. And so we have a kind of some guidance coming out in the next few weeks that should really be helpful in helping centers organize and be able to do that for patients. And that really comes with it the ability to do some of the studies that we're working on in our laboratory now, which is taking samples from patients that we have not only their histology, but more information about their mutations and being able to actually make models of them and cell lines and study them in great detail. I think really being able to understand what those initial inciting events are from our early detection tests and really saying, well, we know that endometrial cancer patients are probably going to develop, we know PTEN mutations occur early, PIK3CA mutations. If we can really map those out and follow patients from the early pathogenesis to, when they walk in the door, then we can understand how to intervene earlier. So making models, making access so we can start collecting samples is one thing that we found is an important first step.
Yep. And I think even sort of at a higher level, I think it still happens. I was talking with Dave much about this at the last podcast, but sometimes you see patients come in, their tissue doesn't even get mismatch repair testing. And, a lot of these things fall by the wayside, but to have a clear guidance and universal guidance about what tests should be ordered and how they should be done and getting them done quickly is really critical for patient care. Certainly even started with surgery and then the systemic treatment and radiation therapy. So I totally agree. I want to finish up by getting your thoughts on where the field of endometrial cancer is headed. I know that you and I could talk about this for hours regarding the topics, and we've already touched upon this: early detection, prevention, therapeutics, etc. But which aspects of the endometrial cancer field do you think will change more rapidly? What are you excited about? Those sorts of thoughts from you.
I think you talk to a lot of people that have great thoughts on some of the exciting things in the therapy side. When I was starting to get ready for this podcast, I looked back and I saw your conversation with Joyce Liu, who said, I'm very excited about ADCs from several years ago. And I think all of those therapy lines of ADCs, thinking about what we're going to be treating patients with after immunotherapy, are really exciting. I think when I look at the endometrial cancer field, I think our biggest revolution is going to be starting to go back to the beginning, starting to understand the disease biology to tailor our therapies to patients. I think, as you touched upon just a few minutes ago, thinking about how we can tailor our everything from surgery, radiation, and treatment based not on histology, but on mutational profiling, on expression, is really going to be where we can revolutionize things. And I think we're going to be more akin to the breast field, I hope, in the next few years, how we're doing that. I think that seeing the research take off is really going to be, the research part of this is going to be really important. I think the research that's being done on DNA damage, on how we sequence things like ADC therapy and our immunotherapy is going to be the first places that we see a lot of changes in the next few years. But I also think a second wave will hopefully be us learning to treat and diagnose this disease earlier. So we're kind of moving to more, I would hope, more surgical management, more adjuvant therapies that are effective.
Yeah. And I like your idea about what the breast cancer teams have done is kind of to scale back on treatment where not everybody gets, drug X, drugs Y, and radiation, et cetera. So to really tailor things better, understanding the biology and the genetics of the tumor. And I think you've made other important points here about the funding, and certainly I think some at least preliminary excitement that the NIH budget looks like it might be increasing, which is quite remarkable. And really the importance of you as a surgical researcher, basic scientist, are out there applying for grants, because I think if we don't apply for them, they'll go to another cancer. So endometrial cancer really deserves this funding. Any other thoughts or ideas that you'd like to mention?
what's been helping to support some of this work is also the recent NCCN guideline changes that are recommending that we do sequencing earlier in the care. And I think that that is a really nice advantage that I think for other gynecologic conditions as well, and for kind of putting in stronger wording in the last few years has been incredibly important to help push this mission forward. So that's been one thing I'd like to mention as a nice positive, and definitely encourage that we have more collaboration in the field to think about bigger consortium studies, to think about obtaining more sequencing information and more collaboration in laboratory-based studies.
So, Jess, it's been great to have you on today's podcast, and thank you so much for joining. It's really an honor to have you here today.
Thanks so much for having me, Ursula.
So today we've talked to Dr. Jessica St. Laurent about several different topics. We've talked about SWI, SNF complexes, their role in endometrial cancer, and what Dr. St. Laurent's doing about SWI, SNF in the lab and her research. We've talked about what it's like for a gynecologic oncology surgeon to have a basic science lab. We've talked about GLP-1 receptor agonists, and we've gotten Jessica St. Laurent's thoughts about where the endometrial cancer field is headed, and certainly it's a very exciting time. So thank you so much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on endometrial cancer. This is Dr. Ursula Matulonis for the Medscape In Discussion Endometrial Cancer podcast.
Thanks for listening to Medscape's In Discussion Endometrial Cancer podcast series with our host, Dr. Ursula Matulonis. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on endometrial cancer.